well, because for a learning point, it's something that we're seeing a lot more of recently as well. I know in my my last month at 3 North, I think at one time we had 4 or 5 patients in the unit who were catatonic, which is kind of unusual for 3 North. For some reason, rates of catatonia are kind of going up, it seems, at least from my anecdotal experience. And it can have some very serious outcomes if we don't realize it and treat it properly, unfortunately. So this is kind of just an overall overview. We'll try to get through as much time we have. If there's anything left over, I can do a different presentation, or I'll send the slides out for everyone. So just going through history of catatonia, it was first recognized in the 1870s by a German psychiatrist, Dr. Kahlbaum. It was literally later adopted into use by another German psychiatrist, Dr. Kraepelin, and he associated with dementia praecox. If you ever heard of dementia praecox, it was actually the proto-diagnosis for schizophrenia. Who Dr. Kraepelin was primarily working with were actually schizophrenic patients he called dementia praecox, and then that became schizophrenia. As a result, early on in psychiatric history, catatonia was strongly associated with just schizophrenia and other psychotic disorders like schizophrenia. The early DSMs, actually DSMs 1 through 3, said you could only get a diagnosis of catatonia if you're a schizophrenic. This changed in DSM-4, where there was unspecified catatonia, and then DSM-5 actually changed catatonia to its own diagnosis. So historically, a lot of older providers actually view catatonia primarily just a diagnosis of schizophrenia or psychosis. But that's not necessarily the case. Epidemiology, catatonia is very prevalent in psychiatric hospitalization. The prevalence actually varies depending on what rating scale you use. Different rating scales and different diagnosis criteria have different sensitivities. One study of a group of large hospitalized psychiatric patients found that using DSM criteria, 12% of patients in the hospital were catatonic, and using the Bush-Francis rating scale, 30% were catatonic. As a result, the prevalence varies widely based on the screening rate as well as provider preference, since it's very subjective in some ways. Prevalence in hospitalized psych patients is between 8 to 40%, so quite a large range. Again, that varies depending on the acuity of the unit. A large meta-analysis published a few years ago of dozens of studies in catatonia dating back decades looked at the most common reasons for catatonia. They found actually the most common reason for someone to be catatonic was actually a medical issue, a non-psychiatric issue. And we'll talk about that in a second, but a lot of medical issues actually cause catatonia as well, or catatonic-like pictures. About 20% of patients in the study who were catatonic were actually medical patients with no specific psychiatric issues going on. This is followed by bipolar disorder, postpartum psychosis, and then schizophrenia as the 4th most common reason for catatonia. Again, showing that schizophrenia isn't necessarily the most likely cause for catatonia. So the mechanism of catatonia, this please is really bothering me. The mechanism of catatonia is still not fully understood. This is kind of a theoretical model of it. There's good evidence using immune assays, fMRI studies, that there's a decrease in GABA-A functioning in the thalamic and cortical regions of the brain, which makes sense why we give people benzodiazepines to increase GABAergic functioning. There's also growing evidence to show there's hyperactivation of glutamate and NMDA receptors in those same regions of the brain. There's also fMRI studies showing that there's a downstream inhibition of dopamine release in the basal ganglia and possibly the cortex as well. Which is one of the reasons why if someone's concerned for catatonia, you should tend to not give them dopamine antagonists unless absolutely necessary, because they could possibly worsen the underlying mechanism for catatonia. So this is a possible physiological model that's been based on the fMRI studies of patients who are catatonic. This model is very messy and poorly organized. That's unfortunately the best one I could find. The big things to focus on are the ones labeled in pink. So fMRI studies have shown that patients who are catatonic have hyperactivation of the supplemental motor cortex, which is a cortical region just in front of the prefrontal motor cortex. The supplemental motor cortex is involved in motor planning and initiation. But this hyperactivation during catatonia seems to lead to a downstream activation of the subthalamic nucleus and internal globus pallidus. If you guys remember your basal ganglia neuroanatomy, this hyperactivation actually leads to decreased dopamine production in the thalamus and the substantia nigra. As a result, this may be the reason why patients' catatonia get stuck, because their basal ganglia is being hypoactivated while their motor planning region is hyperactivated, leading to downstream inhibition. If I did a poor job explaining that, please speak up and I can try to explain again. There's also an electrophysiological model of catatonia. This actually has been popular. This has been heavily promoted by Dr. Malik here. This graph actually is from a paper he published a few years ago with Dr. Ive. This is most of you or some of you have probably heard Dr. Malik talk about this. If you have any questions about it, I actually recommend asking him because he can really explain better than I can. But his theory, especially with bipolar disorder and catatonia, is that it's a electrophysiological problem going on. If you remember from neuroanatomy, all our neurons have a resting membrane potential. And for the neurons to be activated, they have to reach threshold potential. Once they reach threshold, then they depolarize and release neurotransmitters. Dr. Malik's theory of bipolar disorder is that during mania, the resting potential slowly creeps up. Basically, that's the slanted line on the graph, and starts to get closer to threshold potential. As a result, these neurons are more easily activated and can result in hyperactivation in cortical regions, resulting in manic symptoms. However, over the course of disease, more and more neurons go past threshold potential, and they reach what's called threshold block. If the resting potential is higher than threshold potential, the neurons basically can't fire anymore, and as a result are inactive. If a few neurons are inactive or reach threshold block, Dr. Malik theorizes that the patients become depressed because they're losing cognitive capacity. However, if enough neurons reach threshold block, or full threshold block, the patients become catatonic because they can't function, have no cortical activity whatsoever. So, which makes a lot of sense. Again, ask Dr. Malik if I didn't explain that sufficiently. Going into the medical causes of catatonia, like I said, is actually study shows it's actually the most common cause of catatonia. About 20% of patients with catatonia have medical issues causing it. There's a variety of reasons. Autoimmune disorders are a common reason: anti-MDA encephalitis, lupus cerebritis, stiff man syndrome, which is kind of interesting. That is anti-GAD antibodies. It's fairly rare. I think Nick saw a case of that recently. It's anti-GAD is GAD is glutamate decarboxylase. It's the enzyme that converts glutamate into GABA. So this syndrome, you actually have increased glutamate and decreased GABA, resulting in catatonia and poor movement. So I call it stiff man syndrome or stiff person syndrome to be more politically correct. Infectious causes, or basically anything that causes effects of the frontal lobe, can cause catatonia. Infectious encephalitis, meningitis, anterior brain stroke, seizures, TBIs, especially at the frontal regions of the brain, can cause catatonia. GABAergic and dopaminergic withdrawal can cause it, which makes sense. Patients with Parkinson's disorder who are on Sinemet, who stop all of a sudden, can develop catatonia. Patients who have used alcohol and benzos, who cut cold turkey, can also develop catatonia as well, besides their other withdrawal symptoms. Clozapine withdrawal is actually something that's actually fairly common for catatonia, which could cause catatonia. I've seen a couple cases of this in 3 North. If patients on clozapine is stable but stops cold turkey, they can suddenly become catatonic. One, it's because likely they're becoming psychotic, and that can cause catatonia. But clozapine is also theorized to have some anti-NMDA properties, which would then make sense why that could cause catatonia as well, because you're having a hyperactivation in glutamate receptors. Different medications and drugs can cause it. Spice is something that's actually been recognized in literature recently to cause catatonia, not surprisingly. Posterior irreversible encephalitis syndrome, or PRES syndrome, is something I've seen. Basically, it's a temporary vasoedema of the brain that can be caused from medications or other interactions. I saw a case caused by chemotherapy for a patient with cancer. This can also cause catatonia, and the patient I saw was catatonic when they developed this. So if you have a patient with no specific psychiatric history who all of a sudden is catatonic, you should definitely at least consider underlying medical issues, because about 20% of patients who are catatonic, it's caused by an underlying medical issue, according to literature. So going to the criteria, like I said, there's different rating scales you can use for catatonia. The DSM-5 has its own. It's fairly simplistic. It includes 12 symptoms you can identify. You need 3 of them to match to be catatonic, and you can explain the symptoms for other reasons. Most of it's fairly self-explanatory. We'll talk about these symptoms a little bit more. But like I said, DSM compared to Bush-Francis, the sensitivity for DSM is actually lower than Bush-Francis. So Bush-Francis, it's the most commonly used clinical rating scale for catatonia, outside of maybe the DSM. It's validated, it's been tested, it's used for most studies I've read on catatonia. It's a 23-item set, so already more symptoms than with the DSM. There's 3 cardinal symptoms, 11 secondary symptoms, and then 9 additional severity symptoms you can rate. To diagnose catatonia, you need only 2 cardinal symptoms. So again, easier than with DSM, or you need 1 cardinal symptom plus 2 secondary symptoms to diagnose catatonia. Then there's an actual rating scale, so you can see how the severity of the catatonia and see if that improves over time. Typically, to do Bush-Francis, you need these symptoms to be present for several hours to 24 hours to be considered a proper diagnosis. Though with catatonia, we know these symptoms tend to wax and wane. So these are the cardinal symptoms of Bush-Francis if you haven't seen them before. The outline is kind of weird how they organize, because the first 2 are cardinal symptoms, then 13 withdrawal is a cardinal symptom. Immobility or stupor is very classic. People just not doing anything, just sitting there like in the chair in EPS. Mutism is also very common, decreased verbal output or a lack of any verbal output. And then withdrawal, basically just poor self-care with catatonia. Big thing with catatonia is also to monitor oral intake. If patients aren't eating, that is a 3 automatically on the Bush-Francis scale. And also can be pretty serious medically. These are the additional secondary symptoms. Staring is something that's present in the Bush-Francis, but not in DSM, which I think is important to distinguish. DSM actually makes no comment on eye contact, which is kind of interesting, but Bush-Francis does. So constant staring has been known in Bush-Francis. Echopraxia and echolalia are considered one symptom, but echopraxia is mimicking the examiner's movements. So in the evaluation, it's recommended to do at times exaggerated behavior, like exaggeratedly scratching your head, and the patient copies that. That's a sign that they might be catatonic. And echolalia is just copying your speech. And stereotypy is just repetitive or non-goal directed behaviors. If you want to review these terms a little more and not familiar with all of them, I recommend go through the Bush-Francis because they give good definitions. Catalepsy is also something that I like doing because I think it's kind of cool to see, is when you put a patient's arm up or any limb and they just keep it up for no reason. You didn't tell them to keep it up, you just put it up and it stays there. That's a sign of catalepsy. Here's additional secondary symptoms. Mannerism is repetitive, purposeless movements, stereotyped words is also something that's in the Bush-Francis non-DSM specifically, just repeating the same phrase over and over again for no reason. The biggest distinction, I think, between Bush-Francis and DSM is rigidity. So DSM makes no comment on rigidity, but Bush-Francis does. And I think that's important because rigidity is a very severe sign of catatonia, because that's a sign you're developing malignant catatonia, which we'll talk about a little bit in a second. Negativism, lacks of flexibility. The last secondary symptom is agitation, which is also present in DSM. Agitation or agitated catatonia is becoming more well known. It really became into vogue in the 90s, it seems, as a possible diagnosis. classic catatonia, someone who's sitting there and not doing anything for hours on end, is been recognized since the 1870s, but there's growing recognition of agitated catatonia. Basically, it's agitation or excitement, repetitive motor unrest for no apparent reason. This often overlaps with stereotypy, where they're doing the same behavior over and over again, but it's fairly violent. I've seen patients who, I saw a patient at Central State who kept running in repeatedly into a door. And once the door broke, they turned around and like walked away slowly. Everyone thought the patient was trying to escape, but after I did an evaluation, I realized the patient was catatonic, just having agitated catatonia, that the patient was doing this. So it's important to note, because if a patient's with agitated catatonia is treated antipsychotics, it can actually make the catatonia worse. Whether you treat with just benzos, it can actually make it better. These are additional severity symptoms for Bush-Francis. These aren't actually necessary for diagnosis, but just for rating the severity and monitoring the severity of the patient's catatonia. Automatic obedience is different than passive obedience. Automatic obedience is a verbal instruction. What the Bush-Francis recommends is telling the patient to stick their tongue out so you can put a pin in it. Most people realize, I don't want to put a pin in my tongue, I want to stick my tongue out, but then the patient does, that's a sign they're catatonic. They're automatically obeying what you're saying. Passive obedience is more of a motor symptom. If you lightly touch their hand and then they start moving their hand up for no reason, that's a sign of passive obedience. Motorically stuck, just start kind of like freezing up, basically. Combativeness obviously is associated with agitated catatonia. Grasp reflex is something that people don't always realize, and it's kind of bizarre. A person develops a neonatal reflex again with catatonia. You can actually test their you can put your hand or your fingers in their palm and they'll spontaneously grasp. It's somewhat bizarre. I've seen that a couple times. An autonomic abnormality is something I'll talk about with malignant catatonia in a second. So this is the Bush-Francis evaluation appendix. It's at the bottom of most Bush-Francis scales you print out. I think it's pretty helpful. It gives you some additional things you can test for if the patient's catatonic. Like I said, the passive obedience, the automatic obedience, grasp reflex. The motorically stuck is interesting. If you ask them to extend their hand and shake their hand, they just kind of get stuck while trying to do so. I think another thing that I know Dr. Clow likes to do is just watching the patient. It's one of the reasons I went into psychiatry. I just like people watching, just sitting there and watching the patient while they're going about their day. You can see them showing signs of catatonia without even interacting with them. If they get stuck, if they're exhibiting echolalia, if they are posturing, it's very useful, especially in a psych unit. Malignant catatonia is something I think most of us are aware of. Like I said, it's associated with worsening autonomic instability, hypertension, febrile, tachycardic, tachypnic, diaphoretic. It also is strongly associated with worsening rigidity, like I said, and ultrametastasis and delirium. And you can have abnormal labs of it showing that's causing end organ damage, elevated creatinine for kidney damage, creatinine kinase for rhabdomyolysis, leukocytosis, and low serum iron are the classic labs to evaluate malignant catatonia. It's life-threatening. It can lead to seizures or even death, and it's emergent to treat. Every year there's always a couple patients in ICU who have malignant catatonia. NMS is something I've never actually personally seen, but it's considered, a lot of literature now considers it basically antipsychotic-induced catatonia, because the symptoms of NMS are basically the same as malignant catatonia. Like I mentioned, giving antipsychotics in catatonia, if this patient is concerned about catatonia and the antipsychotics seem to have an effect, you should really strongly consider just giving them benzos to see if they get better. Because you can go from mild catatonia to NMS very quickly. Again, very similar symptoms: autonomic instability, rigidity, altered mental status. The labs are basically indistinguishable. It's low serum iron, elevated creatinine, leukocytosis. really good evidence to say that MS is a type of catatonia or in the catatonia spectrum. So going back to the medical concerns of catatonia, obviously DVT and PE are a big concern, like we unfortunately realize now, because people are sitting still for days on end, sometimes weeks on end, and they can develop blood clots. Something to be aware of, especially on the psych unit even. There's a risk you give them Lovenox because they're also falls risk if they're catatonic, but they're also a risk of developing DVTs. The other problem too is if you start giving them Ativan, they may start walking again and then they fall, but you were previously worried about DVTs. So anticoagulation is a quick contention among patients that are catatonic, and kind of it's case by case. Obviously, dehydration, renal injury is a big issue. Protein calorie malnutrition, debility from not eating can also lead to life-threatening malnutrition. Pressure ulcers are obviously a huge concern for, and something I think reading through the literature, they're actually extremely common in catatonia, something I don't even evaluate for, something I guess are doing better job of. So just getting a medicine consult for someone who's been catatonic for days, if they're not eating and not drinking, is very appropriate. Obviously, we'll monitor the labs, depending on what their labs show. So treatment, it's kind of an interesting thing when I was reading the literature. There's actually a really good algorithm I'll show later in the lecture that a group out of, I believe, Yale came up with, which I think was really, really helpful. Treatment of underlying of catatonia is fairly simplistic and is very beneficial if done early. So first want to identify the underlying medical cause causing this. This is a psychiatric reason. 80% of patients with catatonia are catatonic because of psychiatric reasons, but 20% are due to medical reasons. Stop or reduce antipsychotics if at all possible. There is evidence that clozapine is better in catatonia because it's less D2 antagonistic than other antipsychotics, and because it seems to have some anti-MDA properties. So there's actually some recommendations of using clozapine as an adjunct for patients with persistent catatonia, or trying partial agonists because there's not as much D2 blockade of partial agonists. There is some evidence for their safety. Benzodiazepines studies show that 80% of patients who are started on benzodiazepines respond within 48 hours, which is a good sign. There's good response rate for patients with catatonia if you address it early, while making sure their other medical issues are addressed. For patients who are treatment resistant, who don't respond to benzos within a few days, ECT is shown to have a 60% response rate among treatment resistant patients. Dr. Kalal could probably explain the pharmacology of ECT a little bit better, but I think we all know it works really well. But I think the big thing with antipsychotics or with catatonia is if you worry a patient is catatonic, trying benzos first makes way more sense, according to the literature, than antipsychotics. Additional treatment options, these are things that have been studied primarily in case reports, and small cohort studies, but don't have huge studies backing up their support. MDA antagonists have most evidence behind them outside benzos and ECT. Mantine or mantidine have been studied quite a bit in several dozen case reports showing benefit. And I know we've been using mantidine in the hospital when we have treatment-resistant patients with catatonia. Again, there's a theory that there's hyperactivation of glutamate receptors in catatonia, so MDA antagonists make a lot of sense. The important thing to remember about mantidine, though, is mantidine does have some D2 affinity, which can be good for catatonia, but also if you're a patient that's psychotic, it could, in theory, worsen the psychosis as well. Anti-epileptics have also been studied. If you go by Dr. Al-Malik's theory of catatonia, it makes a lot of sense why you'd use anti-epileptics, because they're membrane stabilizing and can help stabilize resting potentials of neurons. There have been good case reports of using valproic acid and carbamazepine in treatment-resistant patients with catatonia who have mood disorders, depression, psychotic features, or bipolar disorder, and there are a few case reports showing its benefit. Maybe not so much in patients with psychotic symptoms, though. There's no good evidence for that with pure psychosis like schizophrenia. There are actually 2 ongoing studies of TMS in catatonia. There's nothing definitive for yet. I'd be curious if and when they publish those studies, to see if there's any effect. Again, TMS has some similarity to ECT in its way it works mechanistically, but I imagine the region of TMS, the region of the brain you target TMS probably has to be different with catatonia. Maybe the supplemental motor cortex, the fMRI studies show. Other dopaminergic agents have also been studied in catatonia. Methylphenidate and carbidopa-levodopa have case reports showing it actually helps catatonia, but every case report published didn't show the patients got psychotic on that. So dopaminergic antagonists or agonists maybe aren't the best. Like I said, this is the algorithm that this study came up with. Basically, you always try intravenous, intramuscular Ativan first, or any other benzo. Do ECT if that fails, and then you can look at secondary treatment options, or if you can't do ECT for some reason like legal reasons or patient not consenting, you can try additional treatment agents. The first is glutamate antagonists per this algorithm. Next, you can consider anti-epileptics with patients with mood disorders, and then you can also try some other unusual medications. Possibly Abilify, possibly clozapine for patients with psychotic issues. There is good evidence that clozapine can be helpful in catatonia. So that's all of my, that's all I have for the lecture. Thank you for joining. Does anyone have any questions and comments, thoughts? Again, sorry for the random please that keeps popping up. I don't know why that's doing that.
Hey, thanks, Art. That was a really interesting and beneficial presentation to sit through and go through the different criteria, and even going back to Tyler's M&M and talking about the physiological changes in catatonia. I don't know if you came across this during your research or not. Maybe like a hypercortisolism state of excessive cortisol production, because catatonic state is by itself really a stress-induced state, and we know that cortisol levels do cause an inherent change in coagulation cascade. So in addition to staying stationary and dehydrated and those things, we also have to consider that third factor as well, that despite the nature of being catatonic, even if you're up and about, you are still, I think, should be considered coagulopathic. Did you come across that at all? I mean, there's very little research on it. I think there's a couple articles I found a couple of years ago that talked about it.
No, to be honest, when I was making this presentation, I was primarily looking at large review articles. They were looking at treatment and underlying mechanism and whatnot and diagnosis. There's nothing that I saw that came up when I was reading those articles. I'm going to send out my PowerPoint, and most articles I use are going to be linked in the comment section. If anyone wants to go through those. There were some studies showing that inflammatory markers. I mean, most now know most psychiatric issues are pro-inflammatory in some degree, and especially when you look at malignant catatonia, it makes sense why inflammatory markers are going up. But I mean, that makes complete sense. I'm sure there's a multi-hit problem going on with patients who are catatonic who are developing DVTs and PEs.
Absolutely.
Thank you for the comment.
Thanks.
Yeah, just to jump off of that point, I think it's just important that we revisit catatonia from time to time because it's such an elegant condition that we're still learning so much about. And I say elegant just for the same reason that we can see so much concordance between the physiological changes that we are aware are happening and Specifically, what I'm interested in is the subjective experience of patients who are catatonic, who don't have amnesia for the experience. And we can correlate that with known physiological changes. So, catalepsy, for example, there are, I think, have been like demonstrated parietal lobe changes on fMRI. And essentially what we think of catalepsy is just basically an agnosia for normal limb position in space or normal resting limb position. So if you're not aware that your arm should be resting at your side, if somebody positions it, you'll have no awareness that it's not in a normal resting position, not feel motivated to move it. Cortisol changes, NMDA changes within the amygdala. Obviously, some patients who have memory for the period in which they were catatonic will say that it was the most terrified they've felt in their life. They felt like just intense anxiety, and that if they moved or spoke or did anything, that they would die, essentially. So obviously there's more than that going on, but I think it is a pretty elegant condition as far as like the types of lines we can draw.
I think the big takeaway as well from that, going off that, is that catatonia can present in so many different ways. That's why I like the Bush-Francis scale a little bit better. Even though it may not be most specific because it's so broad, there's so many different ways catatonia can present that two patients' catatonia can look very different at the same time, even if they're next to each other. One can be running into a door multiple times, the other one just sitting there staring at the wall. I couldn't, just from the subjective experience, I've talked to some patients, obviously, after the catatonic, and it just sounds horrifying. It sounds like a nightmare.
Yeah, I guess the bottom line I agree is, like, when in doubt, don't take the DSM's word for it. Look a little deeper.
Yeah. And when in doubt, I mean, assuming they're, unless they have like a severe respiratory problem or like a falls risk, giving them like 2 milligrams of Ativan IM, at worst, you're gonna make them sleep. The one thing that I think people forget with treatment of catatonia benzos is the recommendation is titrate till sedation. So if you are giving someone 20 milligrams of benzos and they're not getting sedated, you can go higher. Obviously you don't want to like be shoving benzos down someone, but there are patients I've seen who are an extremely high dose of benzos and are showing benefit from it. If a patient, you give 2 milligrams of Ativan, they'll improve, they're not necessarily sedated either, you might not give them enough Ativan. You might have to keep titrating up.
Yeah, totally agree. We probably undertreat with benzos, and it's just important. There's some cases that probably a lot of people are familiar with, like currently on consult services, and specifically thinking of a patient at Norton. But it is important to consider if for some reason you're out of options in one area of treatment of catatonia, to consider that you have other medications that you can try if you don't feel comfortable escalating benzos. So think of amantadine, think of things like that. They'll even do that like in the ICU for malignant catatonia. U of L, I've seen it several times, and it can be effective. So just don't give up, exhaust your options.
Well, somehow you managed to use up the entire hour. Any other thoughts before we break off? I really appreciate all the attendance. Thank you, everyone.
I just have a quick question in general. Has anybody seen, like, I know that Dr. Malik has like anecdotal or evidence that lithium like prevents recurrence of catatonia and that kind of thing. I have used it with him twice now on patients, and both of them have become lithium toxic because they just aren't eating and they are moved to the floor. Has anybody seen any benefit from like initiation of lithium during these episodes?
I've seen, I partially saw one because they were starting on lithium as I was leaving consult. My understanding is the patient didn't get better afterwards either. It makes theoretical sense why it would work. Because there are, lithium works very similar to valproic acid and Tegretol, and there's good sites for valproic acid and Tegretol out there. Two things that you need to consider is it seems that there's only evidence for it in catatonia due to mood disorders. If the patients were, do you remember if there was primarily a mood component to their catatonia, or was it kind of unclear?
Yeah, it was a mood component.
Mood component. But again, you're right that like the risk of them becoming lithium toxic because they're just sitting with all the lithium in them and not peeing it out is also a concern. I've never seen personally though.
Cool. Thank you.
Not sure if anyone else has. Cool. I think we'll end it there. Thank you everyone for attending again. I'm going to send the PowerPoints out to the RAC group, and let me know if this lecture was helpful. If there's any nice thing about residence hours, we have opportunities for senior residents to do lectures. If you guys find this helpful, things that might be missed or might need a refresher on. So if there's any interests or things you want to talk about, feel free to reach out to us. Okay.
Awesome. Thank you so much, Tyler and Art. This is very, very helpful.
Everyone have a good day. Bye.